Now, without any further delay, we will move on to our second workshop for the day, which is by Dr. Padmanaban Sekaran. He is the founder director of Movementology Academy, lead tutor of Arthro Rehab, advanced orthopedic rehabilitation, specialist clinician with 24 years of tertiary care orthopedic and sports rehab expertise. He is also a visiting consultant for Emirates Health Services UAE, and he has published author for 24 international peer-reviewed publications, including a coherence review and articles in Journal of Arthroscopy, Journal of Shoulder and Elbow Surgeries, European Journal of Sports Traumatology, and Indian Journal of Orthopedics. He is an international speaker and resource person, delivered over 164 workshops and multiple conferences, talks across India and abroad. Startup mentor at Rehab Tech Futurist and Chief Scientific Officer of Ayyappan V Tech Private Limited. We welcome you, sir.
Check. Yeah, that's perfect. Okay, guys. Morning. I think it's still morning. How many of you have attended one of my courses? Any one of my courses? No? Have you? Yeah, Nabil is here. Yeah, Archita is there. And then, yeah, okay, good. I do a 2-day workshop on athletic shoulder, okay? And I was asked to do 1.5 hours of athletic shoulder. So you know that it's not going to be complete, right? Yep. How many of you think you have an athletic shoulder? How many of you think you have an athletic shoulder? Okay, how many of you do this thing called exercise? You know something called exercise? How many of you do? I don't. Okay, how many of you are physiotherapists here? And let me confirm that. Yeah, cool. I think there is supposed to be a relationship between physiotherapist and exercise. You know what? Yeah, it should be something like, say, maybe a little closer relationship, boyfriend, girlfriend, not the mother-in-law type of. No, now physiotherapists treat exercise as the mother-in-law, is it not? An ultrasound like their, ultrasound and IFT like their, what do you say, soulmate. Yeah. So if you want to treat athletic shoulders, then exercise and movement should become your soulmate. Yep. And I will tell you what I mean by athletic shoulder. How many of you have heard this terminology, athletic shoulder? How many of you have heard this? You know what I'm trying to do? I'm trying to warm you up. Okay. Because I'm going to ask you to do, how many of you know what is a handstand push-up? Do you know what is a handstand push-up? Yeah, okay, fine. So normally I start the courses with a handstand push-up. So if you raise your hand, it will be when I ask you a question, it will be a good warm-up for your shoulder, because you're going to do all of that. It's called as a workshop. You know what is a workshop, right? Yeah. Workshop basically means I talk, you do the work. Okay? Yeah. Cool. Let's get going. Now, what you have to consider is fundamental difference between what you called as a non-athletic and an athletic shoulder is this. Somebody is injured and then they want to do a function. It's easy to put, because you go across the hall, you will see almost every post-surgical outcome, a good outcome will be demonstrated like this. So elevation, flexion, arm behind, arm, and then out, and then the patient is fine. Okay, patient is fine, irrespective of whether the patient is having a throwing arm, lifting arm, okay, punching arm, or just doing household work. You understood? So technically it can be function, But the definition of an athletic shoulder is a little different. You have to, the rehab is not complete till you put them into performance. I'll tell you what I mean by performance. When you have, say for example, injury, any injury to the shoulder, say one injury to the shoulder, just say one injury. You just heard so much. Shall we take rotator cuff? So if either we do non-surgical or surgical rehab, okay, if you give them ability to lift their arm, okay, it's a function. If that is what the patient's demand on the shoulder is, to lift the arm, do household work, that is a function of the shoulder. If that arm belongs to a patient who actually has to throw, throwing, yeah. So when he has to throw, throwing is the function. So if he has a rotator cuff tear, whether you fix it operatively or non-operatively, if you don't give him ability to throw, then you have not restored his function. Does it make sense? Does it make sense? You see, if you go and Google, it will talk about throwing shoulder function. You will never find this terminology, athletic shoulder. It will keep on telling about throwing shoulder and all that. So the automatic assumption is that if you have a athletic shoulder, it means if your throwing is good, you have athletic shoulder. Okay. How many of you watch something called cricket? This is the IPL season. You've seen cricket? How is the shoulder used in cricket? Right shoulder, left shoulder. How is it used? Is it for throwing? Okay. Throwing like this? Throwing like this? Is it used for diving? How many of when you just dive and then land on your shoulder like this? Yes? Is it used for that? Is it used for bowling? Okay. You know what is unique about IPL? Yeah. You have to bowl all the balls different ways. Okay. And you have to bowl multiple overs. If throwing is a function, okay, bowling is performance. You know what is the definition of bowling? What is the definition of performance or bowling performance? You have to bowl better than everyone else who is actually there. You understood? It's not just your bowling. If you know how to bowl, you don't get into IPL. You understood? You have to bowl better than almost every single person. And you have to do it under pressure. And you have to do it in a match situation where you just fielded on the boundary or on the slip or on the cover, where you've just fallen down, picked up a ball, throw it with full affected and a run out, okay, and then you come and bowl again. So that's called as performance. And we go back to the first question. The guy is recovering from a rotator cuff injury and he has to go back to cricket and he has to play at the level of IPL, okay, or he has to get into the team to play in the IPL. He has to demonstrate all these abilities. So whatever you show as an outcome when you lift and all that, and then if they have throwing, okay, it's not complete. Okay, you guys want to know how to put this guy into bowling, or you want to know how to put the guy into lifting the arm against gravity? Okay, I asked you a question. Yeah, okay, we'll say, yes, I want to put this guy into performance. Yes, performance. Yeah, it's option A. Okay, lifting the arm is option B. How many of you are for A? Okay, seriously? Okay, if you guys are not talking, no, I will just mute this mic and then pretend that I'm teaching you something and then walk away from here. How many of you option A? Option B. Okay, somebody has some other option. What is this? Give them ability to kick? Huh? Both A and B? Yeah, if you don't do the B well, A won't happen. Okay. First understand, for you to go either A or B, you have to understand two things. One is, what are the injury characteristics? Right now he said something about the cuff, is it not? So can you put all the patients after a rotator cuff tear into throwing, non-surgically or surgically? Even within surgery, how many parameters are involved before you commit that this patient will be able to throw or bowl accurately better than everyone else? What are the demands of the sport? I just told you what are the demands of cricket. What if this guy is doing boxing? You know boxing? And what if he has a injury to the labrum or the capsulolabral structure? Yeah, he has got a dislocation and he has to do boxing. You know one movement you have to do in boxing? Just show me one movement that you have to do in boxing. This one? Yeah. Can you guys demonstrate boxing movements? Yeah, okay. I think this is a workshop, is it not? I think you have to get up. Yeah. Get up. If you don't get up, what I will say is I will ask you to find a partner and then demonstrate. Okay? Yeah, get up now. Yeah. Get up, get up, get up, get up, get up, get up, get up. Okay. Now, if you are a right-handed boxer, okay, put your hand like this. It's called as a defense. Okay. If you are a right-handed boxer, if you move your left hand in front, okay, if you move the left hand in front, it's called as a jab. Can you do a jab? And in boxing terminology, it is called as the one. You understood? So do a jab. Okay. Now, if you are a right-handed boxer and then you move your right hand, it's called as a cross. Okay. So this is 1 and 2. What I want you guys to do is do a 1 and a 2. 1 and 2. Yeah, very good. Do 1 and 2. Follow my instruction. 1, 2. 1, 2. 1, 2. 1, 2. Okay, good. So jab and a cross. Okay. Then comes the hook. You understood? So when you put your arm like this and then bring it across, it's called as a hook. Okay, there are two hooks. One is on the right hand side and one is on the left hand side. A hook on the right hand side, left hand side is called as 3. Can you do a 3? Okay, and can you do a 4? Now I want you to do 1, 2, 3 and 4. 1, 2, 3 and 4. Okay, then comes the uppercut. Okay, when you do it on the left hand side, it's called as a 5. When you do it on the right hand side, it's called as a 6. Okay, 5 and 6. Okay, 1, 2, 3, 4, 5, 6. Everybody got it? Okay, if everybody did boxing like this, okay, 1, 2, 3, 4, 5, 6, you understood? Life will be boring. Yeah, so that's why in a sporting environment, nobody knows, okay, what is coming next. Yeah, okay, you all know 1, 2, 3, 4, 5, 6, is it not? Do one more time. 1, 2, 3, 4, 5 and 6. Okay, now 1, 3, 5, 2. Can you do it? 1, 3, 5, 2. 1, 2, 6, 3. Okay, that's how at the simplest term the shoulder is used. You understood? So if you don't know, if you don't have awareness, if you don't have ability to integrate your shoulder after an injury, okay, then you can't put them into performance. Can you feel how it requires motor planning, it requires awareness, and you have to understand the demands of the shoulder. Yes, no, demands of the sport. How many of you do boxing? I'm not asking the women because default mode setting on whenever you're married. Okay, so all married women are disqualified from this question. Okay, so how many of you know boxing? Okay, how many of you watch boxing? Okay, how many of you treat a patient who is a boxer? How many of you know cult fitness? How many of you do boxing classes in cult? Okay, fine. Get a life. Come sit down. Okay. So if you don't understand the demands of the sport, you can't treat the patient. Okay. You can't treat the patient. Because if you don't understand the demand that your shoulder has to go here, okay. The patient has an anterior labral injury, anterior labral repair, and he has to do a cross, do an uppercut. It places against somebody who's actually moving in the opposite direction. You know what is one exercise which can fix it? What is one exercise? You want to know, is it not? How many of you know the blue TheraBand exercise? The magic exercise? Yes, no? No. You get the blue TheraBand, tie it in the window, and then pull it 10 times and do it 3 times, 3 sets. Yeah. You think that's which part of this it's going to fix? Nothing. Okay? Yeah. So what are the injury characteristics on a non-athlete versus athletic population? Oh, and then there is something else. If you are boxing long enough, if you are into sport long enough, then your muscle, tendon, joint and movements, there are adaptations. Yes or no? For example, there are adaptation for a throwing shoulder, swimming shoulder. There are adaptation for an impact or a pushing and a punching shoulder. There are adaptation for a weightlifting shoulders. Yes? The tendons adapt differently. Look at the injuries. General population, we are mostly dealing with impingement. Everybody has heard this terminology, is it not? I don't need to repeat this. Impingement, instabilities, rotator cuff pathologies and stiff shoulders. Everybody knows. Okay, physiotherapy career starts with the frozen shoulder and ends with the frozen shoulder. Yeah. For the same patient. Yes, no? Yeah. Good. Athletic population, completely different. If you are dealing with patients and an athletic population, you are talking about things like posterior superior impingement, overuse tendinitis, slap lesions, posterior cuff tendinitis, posterior labral injuries, primary instabilities. Okay, yeah, there is no real dislocations, but they are having instabilities. Imagine this scenario: posterior superior impingement. Where is the pain? Where is the pain? Where is the patient going to complain of pain when they have posterior superior impingement? Good, good, very good. This side, is it not? Yeah. Posterior cuff tendinitis. Where is the pain going to be? Going to be somewhere here. Okay, good. Posterior labral injury. Where is it going to be? Good. Treatment. How do we assess, classify these patients? Because patient is, for us, no, life is simple. If the patient complains of pain, you go and touch the shoulder. Something is tight. And if something is tight, there are two things that you can do. Okay? And get out. The mechanism is this. If the patient is having posterior superior impingement, it normally happens when the external rotation is excessive. Yes? He has excessive external rotation. So he probably has to have the control of that excessive external rotation by training, say, the subscapularis muscle eccentrically to control that range. Does it make sense? Yes, no? Yes, no? I warmed you up enough. Now you have to get used to the terminologies. No choice. If a patient has a posterior cuff tendinitis, it's the infraspinatus which is trying to decelerate. Either he is throwing, serving. Okay. So here it is a subscapularis and here is the infraspinatus arteries. Posterior labral injury happens whenever you are pushed, landed, okay, or something is pressing against you. For example, you have done a bench press. Yeah, posterior labral injury. Primary stability problem. Patient's pain is never the target of intervention. If you understood that athletic shoulders, the pain is not the target of intervention, even for normal shoulders, for that. Function is the target of intervention. If you don't understand the function, if you don't understand the demand, and you treat the pain, you're not treating the athletic shoulder. For that reason, any shoulder. Does it make sense? Because the intervention is going to be different. Why am I telling you this? Why am I telling you this? Why do you think I'm telling you this? Because if I ask you guys to come up with one exercise for subscapularis, one exercise for teres minor, and one exercise for stability for the shoulder, posterior stability of the shoulder, you must be able to do it. Yes, no? Yes, no? Okay, a loud yes will motivate me. Yeah, okay, that's what we are going to do. That's all workshop is. Workshop is not, I'm not going to show you this because you already know. I'll show you the TheraBand and you're going to show me the exercise. Everybody knows where is subscapularis and what it does. I'm only going to ask you guys to say patient has posterior superior impingement and please prescribe a subscapularis exercise for him. Ideally you should have planned for it, but I've made it simple and you're going to do it. Yes, no? Okay, there are two options. Yes, no? Okay, yes, that's all finished. Course over. Now, imagine what happens to post-operative shoulders. You know the best part? Okay, that's a stability debridement in isolation. It's not a great this one, but then when you are trying to protect any of the repairs, you debride it. But primarily, those are the things at the foundational level. Those are the things that we are talking about: stability procedures or rotator cuff repairs. You know what is the best part? The suture material, the technique, okay, the surgeons. All of this will be the same, but the tissue on which you are repairing will be different. I told you about the adaptations. You know what is the best part of this? The rehab will be the same. Okay. Here you are thinking about somebody who has done weightlifting, done throwing. You think his tendon will be a little more different than somebody who's been into physiotherapy as a career? Can you look at your tendons? Yeah. And then you look at somebody who has been throwing, playing, swimming. You think their tendons will be different? Structurally, morphologically not, but functionally it will be different. You have rotator cuff tear, he has rotator cuff tear, you have the same surgery, he has the same surgery. Okay, you choose not to lift your arm because you are a physiotherapist. He chooses that he has to go back to swim and then swim rest of his career. Do you think the rehab has to be different? Yes, no? Yeah, yes? Okay, good. Demands of the sport if you understand. then you know how to put the rehab in place. I already gave you an example of movement demands, which is a combination, correct? It's a combination 1, 2, 3, 4, 5, 6, 1, 5, 4, 3, 2. So combination. Or you just do some isolation, just moving in one direction only. For example, I will show you an isolation movement. There are force demands. Almost every single sport requires plyometric ability. Yes, throw is a plyometric ability. Diving into the pool is a plyometric ability. You understood? Push, pull, jump, land, impact. Somebody is throwing, whipping is a plyometric ability. If you don't have plyometric ability, if you don't build plyometric ability after an injury, there is no rehab. Okay. One plyometric exercise for shoulder. Somebody wants to give one plyometric exercise for the shoulder? Plyometric? Who said that? Come, I was looking for you. Please come. Come. It's called as a trap. Okay. Yeah. I want you to show them how a plyometric push-up is done. You want to get on here? I think it will take your weight. Come. Yeah. Oh, you are that guy who can just ask your patient to do plyometric push-up. Not do them. Okay. Yeah, good. Okay. How many of you know what is a plyometric push-up? Can somebody demonstrate a plyometric push-up? Okay, Vishnu, come. I am going to promise you something. Okay, first demonstrate. Can you come here? Oh, it's going to go on the video is going to go there? Yeah, okay, fine. Plyometric push-up. Sorry? Whatever it is called in your, that one. Okay, yeah, okay. Can you do a clap and then land? Okay. That one is called as a plyometric push-up. Can you do one more time, please? Okay, I'm going to make a promise to all of you. By the time I'm finished with this talk, each and every one of you will be doing a plyometric push-up. You signed up for workshop, correct? Yeah, athletic shoulder workshop. Thank you, Vishnu. It's as simple as that. Good? Yeah. Isometric, eccentric abilities. Power demands, it has to be done under speed and it has to be done under load. And skill demands, which includes you to be sequencing the movement and you have to be precise. Those are the demands of the sport. And I told you about the adaptations when you are rehabilitating. Is this shoulder unstable? Okay, the patient has pain in the shoulder. How many of you want to stretch and release the shoulder? How many of you want to stretch and release the shoulder? Can you see this? This is an Athens Olympics. This guy is a Major League Baseball pitcher. If you understood the surgery, can you see this? Imagine this guy has an anterior shoulder instability and he has undergone a surgery. If you don't restore his ability to do this, then his career is gone, his performance is gone. Does it make sense? Tell me one movement which we have to avoid after anterior shoulder repairs. One movement. That movement, yeah, okay. You're not supposed to go to 90 degrees also. How many degrees is he going? Okay. If you don't get it, career over, no performance. You understood? How do you get him there? Only if you know whether there are adaptations, whether he has got this movement by losing the movement somewhere else. That means he has lost internal rotation and then gained external rotation. Or is he someone who has gained, he has restriction on both the sides, which is called total motion deficit, or he has a total motion gain. She'll have a total motion gain on both the sides because she's a butterfly swimmer, Olympic gold medalist. All the structures here will adapt. The ligament will adapt with laxity. You will have the same ligament, but it will be lax so that it allows extra movement with increased joint stability. Tendons will adapt with stiffness. You know what is the stiffness of a tendon? It's not a frozen shoulder. You know what is the tendon stiffness? Yes? Okay, how many of you know the difference between an yellow TheraBand and a black TheraBand? You know the difference. What is the difference? Resistance. The ability of the tendon, ability of the TheraBand to actually resist the movement. You understood? That property is called as the stiffness. Okay? TheraBand length will be the same. Physiotherapist shoulder, rotator cuff tendon, yellow TheraBand. We will start pink TheraBand. You understood? Athletic shoulder will be black TheraBand. Length will be the same, but the ability for it to produce force when it is stretched will be maximum. And then it is torn, and then you operate on it. And then you do TheraBand exercise. blue theraband. Okay, where does it go? Nowhere. Adaptation and stiffness in the tendon has to be restored. That can be restored only if you load the tendon during the healing phase. Strength adaptations, which will be sport specific, it will be range specific. You want an extra range, so you need to have strength in that extra range. You can't say that I have range over here, strength over here, not over here. Doesn't work. Force velocity, ability to actually change your force. Change this according to the speed. Neuromuscular control, speed is important, accuracy is important. The difference between throwing and bowling is you have to be accurate with a lot of variabilities. Yes, no? Yeah. It has to be in end range or just added range, I don't know. And then it has to be in combined position. Imagine this, you are not throwing like you do in the rehab, is it not? You do rehab like this, but throwing comes something like this. Yes or no? Throwing comes like this. Yeah? Combined positions. There are physiological adaptations. One good thing about athletes is they all start early. Yes, no? They all start early as they are young. So their tendon, muscle, joints are adapted a little differently as compared to non-athletic population. Henceforth, when I say non-athletic population, I will use the word physiotherapist. Yes, no? Yeah, okay, fine. You show me plyometric push-up, I won't use that. Deal. And some of the athletes, for example, if you are dealing with bodybuilders and weightlifters, and these guys come and they use performance enhancing drugs, self-explanatory. Okay, you know what it does to the tendons? How many of you have seen muscle tendon tears in bodybuilding athletes, powerlifting athletes? Yeah, now they are using even in track and field athletes, and the tendons go weak and then it tears, and then you operate and then you expect it to actually adapt to plyometric demand. It will never adapt. So you must be aware of it. Okay, it's not necessarily that he is looking good, his physique is good, so his tendon is automatically stronger. No, it may not be. Okay, this has a significant influence. So the rehab will be different for him. So how is it different? How is it actually different? First, moment of truth. If you go and say athletic shoulder, in Google, the one thing that comes is throwing shoulder rehab. Okay, pitching shoulder, throw a stent. You won't get anything other than that. So the truth is this: not all athletic functions are overhead. I'm going to show you what are the athletic population functions which are not overhead, because the literature is biased towards this. Athletic shoulder rehab is not about stretching something. Okay, it's about stabilizing, because on an athletic shoulder, the stability demands are more than the mobility demands. It's moving in extremes of range of motions and it's moving multiple times. While you do rehab exercises which involves you to lift your arm, elevation, flexion, okay, rotations and all that, the missing link is integrating it with the movement. I told you, with the angle, with the plane, okay, with the opposite limb. You are someone who is actually swimming. You have a shoulder pain on the left hand side. You do a freestyle swimming. You know what is best? Okay, you can't do freestyle swimming like this. You have to do like this. And it has to be perfect. And it has to be coordinated. Okay, with your trunk, with your breathing, with your hip, and then with your foot. Okay, put your hands behind your back. I'm in that kind of mood today. Okay, yeah. I want you guys to show me freestyle swimming with one arm. Yeah, good thing about, that one. Good thing about swimming is you also have to move the legs. Can you move the legs? Come on, with the shoulder and move the leg. It's called movement integration. Yeah, that one. When you prescribe exercises in your clinic and assume that they will swim, this is exactly what you're doing for them. Okay? Does it make sense? This is what you're doing. Yeah. Movement integration is the missing link. How do you integrate your arm? That means your glenohumeral joint to the scapulothoracic. How to integrate the thoracic movement? Opposite limb, neck, breathing, hip, opposite hip and toes, and then with an opponent and moving further. Swimming is the easiest of the learned movement. Okay, and imagine someone having a shoulder pain. You know what is the good part of swimming? Yeah, 25% of the swimming cycle you are in a position called impingement. That's how you do freestyle swimming. 25%. If you have to do a 50-meter lap, okay, which is the most basic before you actually go and become competitive. Okay, you're doing multiple laps. We have people who do 50-60 laps of 50 meters. They're swimming about 5-10 kilometers. Okay, and 25% of that is actually in impingement position. You know this is impingement position? Yes, your impingement position. And then the patient comes and tells you, I have pain during swimming. And we are geniuses, is it not? We know swimming causes impingement. And we are even more geniuses when we prescribe interventions. You know what they say? You tell me that. When you have patellofemoral pain, you are not supposed to climb stairs. When you have shoulder pain during swimming, according to swimming biomechanics, it is impingement, so don't swim. Look at me. Do I swim? Okay. Doesn't work like that. You have the ability to make the tendon resist or able to handle that swimming motion and not react. That's a rehab. Understood? So you have to put them and build that ability. It's possible. Return to sport is poorly understood because if people, at least in upper limb, I think the understanding is almost zero. At least in lower limb, we have a hop test, is it not? There are so many Instagram videos. Yeah, we watch them and we make them. We have that ladder, that agility ladder. People move in their own funny ways. We put it in our Instagram. And then return to sport complete. Poorly executed ladder. Okay. Athletic shoulder, look at this. How many of them are underhand athletic shoulders? Can you all I'm going to point it out and I want you guys to actually say it loud. Archery. You can all read English, right? Yeah, okay, fine. Sound. Underhand athletic functions. You can't say that you don't throw, so there is no athletic rehab for you. Do you understood? They are athletic shoulders. Yes, no? Over and underhand. We are assuming that, you have golfers who come to you with rotator cuff. Yes. Underhand and only follow through is actually overhand. Tennis, forehand, backhand. The backhand slice places a lot more stress on the shoulder. Forehand hitting with topspin places a lot more, stress on the biceps tendon and an anchor as opposed to the serve. Okay, serve is about speed. This is about eccentric control. If you know at what position the patient is symptomatic, okay, why he is symptomatic, your rehab will be different. It's not throwing motion. Does it make sense? Badminton, underhand, overhand. Cricket, I gave an example, underhand, overhand. Basketball. What about yoga and fitness? Nowadays people are into fitness, is it not? You've heard this CrossFit, yes? No? Yeah. And people do also yoga, and you've heard of power yoga. Are they having athletic shoulders? Yes, no? They have athletic shoulders. So almost every shoulder which is being used has some element and demand on the shoulder, is it not? So as a practice, it's easy for us to essentially say that, if you are having pain during overhead pressing movement, don't do pressing movement. Simple, is it not? They won't come to you again. They usually find me. You understood? Yeah, that's how we do. So if you understood this, and if you have the ability to know what are the demands on the shoulder in each of these movements, then you can prescribe patients exercises. Good deal? Yes? No? That's why you are here. I'm going to give you some examples. How many of you know what this is? By now, the reason why I made you say this loud is so that your tongue start moving in your mouth and start producing sounds which I want to hear. Okay, fine, good. What is this? Okay, yesterday India, won compound bow world championship, upsetting the Koreans. It's a big event. The Indians are world champions. Okay, that's a compound bow. Indians are the world champions. Okay, sorry. So when you are shooting a compound bow, you are actually drawing a 70 pound, that's a 70 pound draw. Just look at that movement on the shoulder, what movement he is doing. Perfect. What is that movement? What is this movement? Horizontal abduction, horizontal abduction. Tell me one rehab exercise that you use, that you prescribe, that will make sure that the patient is doing this. Okay, good news. Whenever you do compound bow archery, you have to draw 70 pound. That means 35 kgs every time you draw. And in practice, you are shooting about 108 arrows at least. In competition, you are shooting 76 arrows accurately. The winning point is about how many tens you miss. Normally, somebody misses 2 tens, they are in out of the medal. Okay, somebody they miss 110, they are silver. Somebody who doesn't miss any 10, I mean, that means they are all on the 10 all the time. 76 arrows, sequencing, precision, accuracy, force, all of this. Okay, then they become performers, and that's the demand of the sport. And we don't have, why I put this? Okay, I don't have the picture. Why I put this? That's my archery coach. Also, I wanted to show off that I do compound bow archery. Oh, okay, that's my archery coach. Okay, and he's doing this 9 months after double row repair of the rotator cuff. He's 47-year-old smoker. Okay, you know what that means? The cuff is not great, and he is doing this. How many of you can make out that's a post-surgical shoulder? You can't. That's how we do rehab. You understood? Obviously, the surgery adds to it. Now, rehab focus, whether you want to mobilize or stabilize. So, see this? That's a bony Bankart, and that's a Hill-Sack lesions, and he's a boxing coach. You know what is the difference between a boxing coach and a boxer? Do you know the difference? Yeah. A boxing coach is a failed boxer. That's given. Yeah. So because of the injury most of the time. Yeah. Boxers will move. Okay, and they are on the offense, and their defense is like this. Boxing coaches' defense is this. Does it make sense? Usually against angry housewives who comes for weekend boxing classes. There is something called striking in boxing. You don't punch, you strike. Strike is this. He's a right guy. He's hiding here. You have to be the model. Okay, come here. Hold your arm like this. Okay, turn around. Did you get my coffee in the morning? Yeah, okay, fine. so when put your hand. So when you do boxing, if you're practicing boxing, that's called a strike. That means you touch and go. That's how boxers practice. And then comes people who are fitness enthusiasts who do boxing, usually in the cult gyms, in the weekends. They do, you understood? They take everything against that guy. Look at the position of the arm. What is this position? Abduction, external rotation. Against what? Against somebody pushing you against. Against who? Somebody who has no clue that this shoulder is dislocated. You understood? And this was fixed. You can see it was fixed. And the surgeon is here. Okay, the top surgeon in Bangalore, Rajkumar sir is here. Okay, and that's the coach, and that's the therapist. 5 months post-operative plyometrics. Okay, for a boxing coach. After what we call as, please, thank you. After a bony Bankart, and does something called REM research surgery. You stabilize, and you have to get the demand against somebody punching against. So this abduction, external rotation, avoiding business doesn't work. Okay, this is now about 7 years now. The guy is very successful coach. He's doing pretty well. Yeah, and do you know how many clients you have to coach in a day for so many years? Because that's his livelihood. You operate. You don't put this guy into this position against somebody who's punching with anger. Then your rehab is incomplete. Does it make sense? Yeah, rehab is incomplete. There is no food on his table, and if you continue to do, there will be no food on your table. Yeah, not bad for business. What I mean by movement integration, when I say movement integration, basic movements are your flexion, abduction, elevation, rotation. There are advanced movement which involves you to combine, and there are sport specific movements which has to be force and load. Is it not? Speed and precision. Whenever you see sportsmen, have you seen sportsmen? They are usually lean and agile. Have you seen them? Yeah. You see a conventional weightlifter or bodybuilder, these guys are big and bulky. You ask them to do any kind of movement, they can demonstrate very well in the gym. You ask them to jump and land or do a handstand or plyometric push-up, not going to do as much. Do it multiple times, you have to use something called a stabilizer muscle. For example, you can't punch with a pec. Okay, because the way it is designed is it will punch once with force and then it needs rest. But you can punch with serratus anterior how many times you want. Okay, it is designed to do that job. That's why it's called as a boxing muscle, yes. And whenever you do this, you have to integrate intersegment. So segment is, you have a patient who has a shoulder injury, At least the glenohumeral joint and the scapulothoracic joint has to work in a rhythm. Yes, no? Yeah, work in a rhythm. And the good thing is the glenohumeral joint, if it doesn't work with the elbow and wrist, okay, there is no integration. And if the elbow and wrist is not holding a ball and then throwing accurately, or holding a racket and then pushing, or have the ability to lift, carry, push and pull, there is no integration. It's called human equipment interface, irrespective of what we do. Yesterday somebody had a thumb injury. He was telling me this: I can squat, okay, but if I have to lift the bar for squat, for which I have to just get my thumb slightly under, this is called opposition. If he has flexion, extension, grip, but he can't do opposition of the thumb, he can't get the thumb inside. That small movement will make sure that he is not able to do a back squat. That's how significant it is. But we don't care, is it not? If you can't do back squat with a barbell, there is always dumbbell. Yeah, there is always dumbbell. Multi-segment, multi-joint and multi-limb. All sports are multi-limb. There are single plane and multiple planes, and then closed and open chain exercises, open chain integration has to be done with load and speed and rotation control. Multi-joint, multi-limb, environment is different. Watch her. She has won all the medals in the master swim. Okay, I told you about this example of a swimmer. Can you see? Everything has to integrate at that level. She had an open rotator cuff tear with a slap repair. Okay, injury characteristics are completely different. 48-year-old male smoker, traumatic full thickness rotator cuff, double row repair. Archery compound bow, demands are different. Load, precision. 46-year-old fitness enthusiast, slap tear, supraspinatus partial tear, slap repair, mini open rotator cuff and subacromial decompression, swimming freestyle, sprint endurance. You have to do it fast, okay, in a medium and integrating. Recurrent shoulder instability, Bankart and remplissage, boxing coach, demands are different. You understood? Rehab has to be different, exercise has to be different. You want to know how to do it? Do you want to know how to do it? Yeah, it can be done. It can be done. It's very easy, is it not? I only need one thing from you. Guess what that is? Smart guys. What I want from you? Yeah, you have to show me how to do a push-up. There is no push-up. Push-up is the most. How many of you know what is a squat? You know squat? You know what is a squat, is it not? How many of you can do an ACL rehab without a squat exercise? ACL rehab without prescribing squat as an exercise. How many of you can do this? Yes, no? You can't, is it not? If you can't do push-up as an exercise, you can't do shoulder rehab. Okay? That's the best form of stability exercise, rotator cuff exercise, mobility exercise, strength exercise, okay, load exercise, speed exercise. So if you don't prescribe push-up early in your rehab, okay, for a patient who is recovering from injury or surgery, it has to be prescribed like how you have confidence to prescribe squat as an exercise for an ACL surgery. It used to be dreaded, is it not? Yeah. Now you have to prescribe, otherwise it doesn't work. Same way push-up. You show me one push-up. You show me one push-up. No, I'm not joking. If you're not showing one push-up, I won't be able to tell you how to do athletic shoulder rehab. Yeah. Get on the floor. You signed up for this. Push-up. No, I'm not joking. I'm very serious. I promised you I'll make you do plyometric push-up. Yes or no? So if you don't do one push-up, then I can't do plyometric push-up. It's called as workshop, no? Yeah, okay. You signed up for workshop. Yeah, good. Come on. David, no cheating. Where is Nandan? Gambhir, no cheating. I'm not going any further. Okay? I'm not going any further if you can't do a push-up. Push up. Come on. Dana sir, you have to do push up. No cheating. Yeah. Okay, good. Okay, please sit back. Thank you. Sit back. I have actually made a note of the guys who have actually not done the push up. Yeah, don't worry, you have something else waiting for you. Okay? Nobody is going to be left. They are going to feel bad, no, if you leave them. Yeah, without they were experiencing the course. If you want to put people back to the sport, you have to know how to manage this return to sport. People kind of do a lot of things around, return to sport, hop testing. It's not about this. If you don't manage the injury well, there is no return to sport. For example, if you choose a wrong patient, you choose a patient who has a shoulder instability on a high demand shoulder, and then you try and do non-surgical rehab. You understood? We had a discussion on the group about first episode shoulder dislocation. Okay, you know the best thing about first episode shoulder dislocation, if you just don't disturb it, it will heal well. But we, from a physiotherapist background, love to see the patient is able to do all movement and put it on Instagram. You know what the all movement does? It actually overstretches or allows the capsule to heal in a stretch position, and the capsule become lax. The capsular labral healing is incomplete, while the mobility is good, the stability is compromised. The patient will have one more episode dislocation. Okay, it's not about movement at all. So if you know how to manage first episode dislocation on high demand shoulder, rotator cuff tears, you must know when to refer for surgery. Okay, when you can promise non-surgical. You understood? If you don't manage the first injury well, then there is no return to sport. Most of the careers of athletes are wrecked because you did not manage the first episode injury well. The best thing about predicting that the patient will get injured again is to know that he has an injury before. Okay, ACL, if he had, he will definitely have one more. Percentages may be different, the limb may be different, but he will have. So if you know that it has to be managed well, and you also have to manage the load in an athlete. Isn't that load basically means the load which comes with the exercises in rehab and then with the sporting demand. This is somebody who is doing TheraBand exercises in rehab and doing swimming as a practice, and he is doing it every day. And then every time we add rehab exercises from week 1, week 2, week 3, week 4, week 5, we add 3 more exercises extra. Okay, by the time the patient is on 6 weeks rehab, he is already doing 50 exercises in at least 10 different positions. Okay, yes, and he is doing every day, twice a day. What you started as a TheraBand exercise twice a day was good, and then you added one more exercise and it still maintained twice a day, and then added one more exercises, and by the time he comes to 6 weeks where he is also doing other stuff in his life, you have maintained your rehab because you are doing what you call as progression. Yeah, doesn't work like that. That's called as load management. For an athlete, you also have to monitor their workload in the week, how many repetitions they are doing of their sport, and you know whether it is going to fail, whether it is surgery or for example, patient with a lax shoulder, you mobilize him early, he is going to fail. Patient with a poor quality tissue after rotator cuff repair, if you mobilize him early, okay, or load him early, he is going to fail. So how do you predict? There are ways to predict. Or he has high demand shoulder, there is a risk. And once you know that you have stratified them that he is going to fail or not going to compete performance, then you have to do something to mitigate that risk. I'll show you how we do. So what you do in rehab is what we call as maximum control, and then you leave them and then ask them to play, and you have a control over the play. It's called control chaos continuum. Then he goes into play, you have absolutely zero control because you don't know the sport, correct? If a patient says, can I actually box? There are only two answers, yes, no, yes or no. If he is 6 weeks into rehab and then he says, can I do boxing? If you have the ability to say, you do boxing, but then stay away from your left hook or an uppercut. If you have that ability, that's called as moderate chaos. When he goes and then does boxing every single day against an opponent who is tough, okay, at an uninhibited practice, it's called high chaos. How to understand, meaning if you have an understanding of the injury and what is the task or the sport he is doing, and then how long the patient has been injured or what is the healing potential, you will be able to manage this. This is called as return to sport. Okay, if you have this ability, then you will be able to put them back to sport very efficiently, into sporting performance even more efficiently. We are on time. So load monitoring is what you give as a rehab, what they can take based on the structures of surgical ability and how they will respond. If you have the ability to control this, then you will be able to push them through. Risk mitigation, this is a guy who has had 7 months post-op back gut repair, okay, and he's a footballer and his fear is that he is going to fall. Okay, that one, it's called as false training. Now again, one more case for doing push-up. If you don't do push-up by 3 months, you can't do plyometric push-up. You can't do plyometric push-up against an unpredictable, okay, unpredictable environment. I'm standing behind and then I'm pushing. How many of you want to experience this? I'm in that mode to show you this. Any volunteers? Come. You didn't do plyometric push-up, you can't do this. Yeah. find your partner next and then repeat this. Okay, you know what this is. I'm going to push you and that's all. It's very simple. Okay, the only thing that I'm going to do is, this guy, imagine this guy has undergone shoulder surgery, yeah, and he has to, next time he falls, the shoulder should not come off. If your rehab is done very well, the discharge should be, this is the discharge criteria. Okay, you have to build him up for this. So if you can't, you understood, this has to be unpredictable. Okay, there are two elements of unpredictability in it. I'm not going to tell him that when I'm going to push him, I'm not going to tell him how fast or how forcefully I'm going to push him. Okay, one more unpredictability. Put your hand here, by the side. Yeah, that one. Okay, stay there. I'm starting him in a position of disadvantage. You understood? Yeah, shall we tie his one arm? No, I was just joking. Come on. Okay, yeah, I normally don't go that far. Okay, because if it fails, you don't have multiple choices. Normally I send this to the surgeons. These videos are shot for the surgeons, so that when they see these photos, they normally fall off their chairs. Okay, okay, good. So athletic shoulder is this. You have to understand that rehab, based on the injury, based on the demands and based on the adaptations, the rehab has to go all the way from injury all the way to performance. If you know that the athletic shoulders are not overhead, not all of them are overhead, and you have to focus on stability. If you don't have good stability, you can't do this. Thank you, it was good. Okay, I'll call you again. And you have to integrate the movement. And how do you integrate movement and how to put them into sport? This is how you do athletic shoulder rehab. Everybody happy? Now we'll do a workshop on it. I'm going to get somebody with a shoulder injury all the way to do this. And you're going to do this with me. Okay? There are two parts. One is you use your body, and the second part is you use your mind. Which one you want to use more? You already showed me what you do with the body. Okay, so better we use the mind to start with. Okay. Yes, no? Yeah, okay, fine. Good. I'll give you three case scenarios. Okay, very easy. We'll leave out the surgery part. I've shown you what to do with surgery. That's a big way to load a surgery, post surgery. I will show you how do we do non-surgical shoulder pain in a weightlifter. Can you see this? Can you see the downward rotation? You know what is a scapular downward rotation, correct? You lift your weight, and if the scapula is coming, how do you assess him normally? You assess him normally, you lift it, scapula is all fine. And in physiotherapy world, scapular dyskinesia doesn't exist. Yes or no? Because you assess him. When do you assess him? You assess him with his lifting his arm up, and then make assumptions about what goes through when he is lifting overhead. His symptom is when he is lifting overhead. Your treatment is not complete if you don't give him ability to lift overhead. Yes? No? And when you saw him lifting overhead, and that's what is happening, there is a scapular downward rotation. You all know what is a scapular downward rotation. Yes? No? And he will have symptoms related to that. A patient with, all of these are real patients, so I don't make them up. Yeah, these are all my patients. I can't show you the entire program. That's what I do in the courses. But I will tell you what I mean by rehab. Shoulder instability in a badminton player. You see, badminton player, if he's not going to go here or if he's not going to go here and then smashing, rehab is incomplete. And he has a dislocation, and he has a first episode dislocation, operated, and failed after a year when he returned to sport, because at 11 months they said, okay, now it's 11 months complete, go and play sport. What happened? It came off. Yeah, it's not about the time, it's about the capacity. Seriously? Oh, that's what I've been timing. Yeah, okay. I don't care. I'll make you do 10 push-ups, course over. Okay? Yeah. Yes, his primary problem is laxity, and you have treated patients, is it not? He says, I am fearful. Apprehension is his problem, and apprehension during smash is not good news for playing badminton. You understand? You can't play badminton like this. Okay? That's in the movies. This is badminton. How do you fix this guy? Slap injury in the calisthenics athlete. You understood? The basic calisthenic movement, I'm not showing any Instagram movement, is to do a dip. Imagine what happens in the shoulder, and it's a slap. You all know what is a slap injury, is it? And it's a biceps anchor problem. So he has a biceps load whenever he loads the biceps, and he has symptom. and he has end range instability. The best thing about calisthenics is you have to move the shoulder to extremes of range of motion with full control. If you tell this guy, tell each of these guys, don't lift shoulder weight overhead, don't play badminton, please don't do smash, abduction external rotation is what is causing this dislocation, don't do dip, don't do pull-ups, okay, don't do push-ups, okay, try some weights and do TheraBand exercise, you'll find someone else. Do you understand? These are real patients, real scenarios, very simple. I want you guys to give me treatment solutions. How do we build a treatment solution for these patients? How do we do a rehab program? If you know there is patient's problem is scapular downward rotation, everybody knows how to identify a scapular downward rotation. Yes? Yes, no? Yeah, okay. Now you want to know why this is happening, why this is symptomatic on this patient, why is this happening? Yes? So you have to do one exercise to fix the why. Okay, did I tell you that exercise is like your soulmate? I use something like that. Okay, if you don't use exercise and you are with needling and ultrasound and IFT, you are in the wrong place. You can't fix this guy. Yeah. Scapular downward rotation, you have to know why and then give me one exercise for that why. Why is it happening? If you have to put this guy back to this, there should be a priority. Give me one priority exercise. You understood? That means if you don't fix this, this won't get better. And he has an athletic shoulder. Okay, you need to progress the exercise, otherwise he can't go back to his athletic activity. So the way you treat him is at least do 3 exercises with why this is symptomatic, what is a priority so that the symptom changes and the movement improves, how do I progress so that he is able to get back to the sport. Easy exercise, meaning for you. Yeah, I want you to. Is that how we think shoulder rehab, or should we think something else? I have a TheraBand, I have a resistance band, resistance band, I have dumbbell, I have kettlebell, okay, and I can plan exercises, 2 TheraBand exercise, 5 kettlebell exercises, okay, 2 kettlebell exercises, 2 sandbag exercises, rehab done. That's not what I'm here to teach. How many of you are following what I'm trying to do here? You following now? Okay, patient has scapular downward rotation, and the patient is having symptom when he is lifting his weight overhead. That's when this is giving him trouble. Otherwise he is fine. Easy solution, don't lift weight overhead. Okay. Difficult solution, fixing this and giving him ability to lift the weight overhead. If you understand these things, then you will be able to prescribe. How do you want to do it? You guys want to come up with the exercises? Yes? Okay. Parthiban, can we pass on the mic? You want some time? Shall I give you 2 minutes to meditate on the slide? Yeah. If you guys don't understand what I'm trying to say here, please ask me I will explain this again. How many of you don't understand what I'm trying to do here? Yeah. What is the doubt? You've been here from first slide? Yeah, okay. What is the doubt? What is the...
What exactly is he?
You understood the scapular downward rotation?
Yes.
Patient, when he is lifting weight overhead, he is having scapular downward rotation, and he is having symptom, and he has difficulty in lifting weight overhead, and he loves to do, lifting overhead. He has come to you telling, he never came and told I have shoulder pain. He says I have pain when I lift the weight overhead, and I'm a CrossFit athlete. I have to lift, and I have to progressively lift more. That's the aspiration. You understood? So let us say shoulder screening, he has impingement, some tendinosis, but no structural failure. That means he doesn't have a slap tear, he doesn't have a rotator cuff tear and all that. It's more of a functional and an overload problem. You have to fix this guy. That means you have to put him back. You understood? You can't put him back till you correct his upward rotation of the scapula. Everybody agrees? Do you agree on that or no? That's why people come to physiotherapy, boss. Okay, there is no anti-inflammatory ultrasound. The guy has gone to the pharmacy, he knows what is an anti-inflammatory medicine. Okay, one time in life if somebody prescribes, it works, he will get it himself. Okay, and then he has gone and did probably a steroid injection, whatever, he has done everything. Because you don't correct the mechanism, the why, that's why he keeps coming here. You understood? It is your job to fix the why, because scapular downward rotation is physiotherapist's job. Yes, no? Yeah? Okay, so I'm asking you to come up with 3 exercises. I'm just suggesting that at least 3 parts of the 3 parts of the problem you have to address. One is, of course, why this is happening. Second is you prioritize that one thing, okay, so that he is able to make progress faster. Third, because he is an athlete, it's an athletic shoulder, you also have to plan for one progression, okay, otherwise he is not going to be able to lift. Yeah, so I want you to come up with 3 exercises. I will give you 2 minutes or 3 minutes, okay, 1 minute for one exercise. Yeah. Yeah, think about it, pick up the mic and tell me for why, this is why it's happening and this is what I will do. If you have problems in thinking, I have a solution. Let us first give you 3 minutes without interruption, and then I will tell you what my solution is. No, what about it? Yeah. It's okay, it's okay. It's okay. Yeah, 1 more minute you have. Nobody leaves the hall. No, I think it's gone. It's like as if I'm presenting. Wow, I think I'm counting the seconds. I think okay, who wants to tell me? How many of you see patients with scapular downward rotation and impingement? How many of you see patients with scapular downward rotation and impingement? Now next question would be, how many of you treat patients with shoulder? My clinic don't have shoulder patients. Okay, for today. For today. I only see knee patients. Okay. Yeah, everybody is silent. No, if you don't commit errors, we don't learn. Is it not? Yeah, please commit errors. I will promise you one thing. Whatever option you say, it's not going to be there. So please attempt. I was just joking. I'm sure you guys know what I'm talking about. Okay, first, this case, okay, I'm going to make it easier for you because this is the first time you're doing this, is it not? So I'll make it easier for you. Yes? Yes or no? Please, loud as. I also need motivation, boss. I ask you something and then you guys sit silent like this. I don't know whether I've said something wrong, okay, or this is Greek and Latin, yeah, or you're all shy. We'll accept you're all shy, okay, so I'll make it easier for you. So most of the time, inadequate upward rotation is the problem, is it not? Inadequate upward rotation. You have to give him at least one exercise which is serratus anterior, that's the upward rotators, and you have to do it in a way, don't shake your heads now like this and all that, okay. So you have to give it in a way that it works in the inner range. So for example, biceps, this is the outer range, middle range and inner range. For the serratus anterior, okay, this is the middle range, okay, and this is the inner. That means the muscle has contracted maximum. You all know an exercise called as this. What is it called? It's a bear hug, is it not? So serratus anterior exercise is not a bear hug. Okay, this is a pec hug. You understood? So if you want to do serratus anterior inner range, then you put your arm into external rotation, okay, and then point it towards the ceiling, and then push away, and then imagine that you're hugging a big tree, okay, and mostly it's branches. Okay. Today is Sunday. Okay, call Jesus along with it, something, we may get some blessings, okay. Yeah, this is called as the Jesus exercise, okay, serratus anterior inner range, and if you can do it against the resistance band, can I have a resistance band? Yeah, this is a mistake people do, okay, you do this is a protraction, you understood, which is also serratus anterior. If you have a retraction problem, then you can prescribe protraction as a prescription, but if the patient has upward rotation as a problem, then the angle has to be here, and then that's where you have to be. You understood? That's how you do serratus anterior. Did you notice? Oh, okay, fine. Oh, that's me. Yeah. Yeah. So if you do this versus this, there is completely different. It's the same muscle, But then the purpose of doing this is different. Okay, Benjamin. Yeah, you're going to stay here with me. Come. Yeah, hold this. Okay, I'm going to show you one exercise and you're going to tell me what exercise is this. What exercise is this? This is a serratus punch? Yeah. This is a serratus punch. It's also called as the useless exercise. Yeah, okay. Imagine what you're doing. You're punching and punching across and then you rotate. You know what muscle works? It is biased towards your pec. You understood? It's not a serratus punch at all. They have been teaching you wrong in your... How many of you are doing MPT? Okay, if you do MPT and if you have to pass exam, please don't listen to me. Forget once you leave because you will fail. Yeah. So if you want to do the serratus punch in a range, okay, come, stay behind me at that angle. By the way I have anchored the band. You see I have anchored the band. You see what I have biased? I have biased upward rotation. You understood? I have biased upward rotation. And I'm not going to adduct and rotate. Okay, I'm going to reach here. You understood? That's how I add resistance to this movement. And I want to integrate my thoracic spine. I integrate my thoracic spine. That's how I integrate. And I want to integrate my core. I just go on a lunge and then I start here and integrate my core. This is a serratus stabilizer bias progression. It's good. I wanted you guys to say in a range hold. Priority 1. Otherwise it's not going to work. Cool. Now, any weightlifter will have a stiffer lats. Have you seen these guys? They all build up lats. Okay, because that's a show muscle. Whenever you build a show muscle, you know what happens? It becomes short. Your biceps become short. That's why it gives you that shape. Your lats become short. Lats is attached to the inferior angle of the scapula. You also do overhead activity under speed. Okay, it's not that it is not stretched or it's not long enough. It is long enough, but it doesn't achieve that length fast enough. Okay, because of the muscle stiffness. You understood? Not muscle tightness. Muscle is normal, but it is stiffer. So it doesn't come, you lift and then you carry, it's not lengthening fast enough. And if it is not lengthening fast enough, then when you come into the overhead position, the scapula is not rotated adequately. So if you don't fix the lats length in this guy, you can't do this. Okay? So that becomes a priority. Give me one exercise for him to fix lats length. Don't tell me IASTM. I've taken that out of the window. You understood the reasoning behind this? Okay, how many of you are having fun? You're enjoying this? Yeah? You understood? This is physiotherapy, by the way. I'm not teaching you anything else. Okay? Simple exercise prescription, that's all. Okay? You understood the reasoning for the lats length? Okay, if the lats length is not there, then you can't lift up. That's a scapular downward rotation. That's the reason. Yeah. So give me one exercise to fix this lats length. Stretch the? What is the agonist muscles for lats? Trapezius?
Yeah, we can say.
Possible?
Yeah.
Okay, good. Lats. What will you do to stretch the lats? Dead hangs. Who said dead hangs? Okay, perfect. Okay, he has to do what we call as dead hangs. You understood? He's going to hang this way. Okay. The best part about dead hangs is, okay, you are stretching this with a body weight. And you don't need to do it in your rehab. Okay. The dead hang can be also held for longer time. For somebody who has a stiffer muscle, your stretch has to be held to up to 30 seconds to a minute. And the only way by which you can't stretch a bodybuilder's lats by the way it is described in whatever book you read. You can't, because it is adapted to his load. And the best way to prescribe this is either with a TheraBand, or the best prescription for this patient for the lats extensibility is a dead hang, because he can hang for 30 seconds to a minute. And you put it in the warm up. You understood? So he has got adequate extensibility. And next time he lifts, the shoulder comes up. You understood? Easily. So that becomes a priority. Everybody getting it? So we have got a serratus anterior inner range hold. We have got a dead hang which goes before, so that the serratus gets better. And the downward rotation can also happen. Can somebody? Benjamin, come on. Okay, can you stand here please? I hate tall guys. Okay. Yeah. Normally this has to be done kneeling down, but you have been a nice guy, so I'll hold you. Okay. Go into a squat position. Go into a squat position. Yeah. Okay. This is overhead. He's doing overhead load, is it not? How many of you have seen patients who is doing a barbell and they are asymmetrical in one side more than the other? This is what is happening. The load is causing the downward rotation. Possible? It's not the serratus, it's not the lats, it's just the load. It's a straightforward, simple load. Okay. And this is a position, this is abduction and external rotation in full elevation. Yes, abduction, external rotation in full elevation. Yes. And he is in abductor and external rotation in full elevation. Is it a stable position for the shoulder? Unstable position for the shoulder. It's the most unstable position for the shoulder. If the shoulder is not stable enough in this, the load is more. Will it be compensated by a downward rotation? That's what has happened to this guy. So if you want to progress his load, if you give him, you have to ask this question, at what load you are symptomatic? He says, when I do 35 kilos, I'm all right. But the moment I put 40 kilos is when I'm painful. Answer, why you do 40 kilos? Look at me. Yeah, okay. According to science, you have to stay at 20 kilos. You understood? You will find that paper. Usually it will come from England. Yeah. So you have to give them ability to lift 40 kilos, is it not? So you have to break through that performance barrier where the injuries, the pain is happening. Yes. So how do you break through this? If you understood that stability is the problem, not the strength, because you assess this guy, his strength will be perfect. You understood? Not an impingement position. So why is he symptomatic? Okay, because of the load. That's why the downward rotation is happening. So you put him on one exercise which improves stability at this. What is the stability exercise here? What can be a stability exercise overhead? Can somebody tell me what can be a stability exercise overhead here? Under load? You have a bar? Yeah. Kettlebell? Good. Do you have a bar? You don't have a barbell? You have a barbell stick? You have a stick? May not be sufficient. Okay, barbell. Okay, hold both the arms. Okay. So imagine he's actually holding the barbell. He's actually holding the. We don't have a barbell, is it? None. Yeah. We have a yoga mat or the foam roller, something which connects both the. Yeah, good. Hold it like that, fold it, both. Yeah, up. Yeah, that's his problem. You'll be surprised to see all these patients, when they lift overhead, either they are down here or they are compensating by excessive elevation. Squat slightly, you understood. So if you actually give him, hold it strong. Okay. If you are actually prescribing an exercise, stability exercise for this guy here, that will be a stability exercise. That will be stability. You know why? Because you are challenging the trunk stability. You understood? Challenging the trunk stability. Push against my hand. Push. Opposite direction. Push. In front. And then back. Yeah. Front. And back. And hold. You understood? So those are 3 exercises that you would do for this patient who came to you with pain while lifting the arm overhead. Is this fun? Because it involves some amount of thinking. If you don't understand the movement, if you don't understand the injury, if you don't understand the meaning the biomechanics or movement, then you can't prescribe exercise. How many of you feel that the TheraBand external rotation exercise would have fixed his problem? Okay. You know what is why we have to do this? You know, we are in the era of ChatGPT. You go to ChatGPT. I'm sure everybody has the app. Okay. Yeah. The guys who are going into MPT exams, especially. Yeah. Or you have to submit your thesis. You go to ChatGPT and then say the patient has scapular downward rotation, give me 6 exercises. You know what it will do? Just do it right now. It will give you 6 exercises, perfect for scapular downward rotation. You know who else has ChatGPT? Patient. Okay. And imagine the guys, your patients are smarter than us. We always start with that assumption. Okay, at least by using technology. Physiotherapists are the most technologically handicapped persons in the universe because they have got exercise. You understood? Biomechanics. Doesn't matter. Patient says that I have 6 exercises. He can print it out and he can actually prompt the ChatGPT and then say, can you give it with a video demonstration? And can you make the person who is demonstrating wear a pink color or a green color top and a bottom? You think it's not possible? Yeah. And can you break down this exercise Okay, act as a physiotherapist and break down the exercise. This is the era you are getting into. And if you don't know how to customize the rehab like this, then you will become obsolete. Okay, and we'll be doing ISTM and dry needling, nothing wrong with it. Okay, your patients came to you for pain during function. You understood? After trying all of this, and that's how you fix this. Everybody happy with doing this? Everybody happy? Happy people usually smile. Can you see your smile? Yeah, okay. Yeah. Yeah. Thank you, Benjamin. Shall we go to the next case? Yes. Yeah. Yeah, please. What should be the? Okay, the prescription is different. I'm not going to do it under load because it's a neuromuscular exercise, it's a stability, so it will be done for time, for fatigue. Most of the time the load becomes a problem when there is fatigue and it's not able to hold. So the prescription will be fatigue, prescription will be hold time. For this exercise, prescription will be hold time. Okay, and for the dead hang, I told you it is the stretch and hold time, which is 1 minute. Okay, here it will be a 10 seconds hold multiple times in the inner range, quality of movement. Okay, as opposed to compensations. And here it will be the perturbations for time, and then multiple perturbations in multiple challenging positions with unpredictability, because it's a stability exercise. So the prescriptions are different. Okay, we'll come to that. You understood? So that's how you choose exercise. Shall we go to the next one? People, okay. Yeah. Yeah. Day one. Day one. Day one. Okay. So these are exercises which will start at day one. There are advanced progressions for each one of them. Okay. For example, you do a reactive neuromuscular training. That means you are doing it against an external load like a TheraBand resistance. Then that would be the progression. But this will be the day one. That's where the treatment starts. Shall we go to the next case scenario? Easy. Shoulder instability, badminton player, primary problem laxity and a fear of the movement that will cause dislocation. You guys want to attempt this? 5 minutes? Okay, fine. You want to attempt this? Yes, no? Yeah? Attempt. Why is he having apprehension? What's this injury? It's an injury to the stability mechanism. In this case, it's a capsulolabral complex. Can you fix it, structure? Yes, no? Yeah, okay, fine. What would be a priority for him? What would be a priority exercise for him? You can keep it simple. Priority can be a stability exercise. Should it be a closed chain or an open chain exercise? How many of you say closed chain stability exercise? For open chain stability exercise. Okay. What would be a progression for him? He has to go here in this position, is it not? Is that a progression? Irrespective of how much you put the exercise here, if you don't progress here, it won't make sense. Okay. Because you gave me only 5 minutes, Benjamin, I'm going to rush through this. So for a capsulolabral dysfunction, you have to do loaded proprioceptive exercise. You understood? The best way, because the structural stability is compromised, and if you want to improve the stability mechanism, you have to engage the capsule and its proprioceptors or mechanoreceptors. Good news, it gets engaged whenever you load it. Okay? Very good news. The exercise that you have to do is called push-ups. You understood? So I'm not going to rest until you guys do plyometric push-ups and get out of this place. Yeah. So if you are doing shoulder stability, either post-surgical or non-surgical, if you don't do push-ups, there is no rehab. End range control comes if you have eccentric control, is it not? Abduction and external rotation, if it is controlled by subscap eccentrically, then the patient has good control in the outer range and you are able to address apprehension. And if you don't give him end range neuromuscular control, because the guy is going to do this, is it not? So you have to have the end range neuromuscular control, which basically means he anticipates the movement, recruits the right muscle at the right time, and then positions his body in such a way that he is able to execute the movement. You understood? End range perturbations. So those are the priorities. Can you guys give me an exercise for this? Okay, I'll make you do something. Yeah. Can you all get into the push-up position? You don't want to do this? You have to feel this. Okay, push-up position. Okay, push-up position. Okay. I don't want you guys to do a push-up. I don't want you guys to do a push-up. You know what I want you guys to do? Yeah, hold the push-up. That's all I want you guys to do.
Oh, 1 minute push-up.
Yeah, hold the push-up. No cheating. Yeah. Go partially down, halfway. Okay, halfway. Okay, what's your lucky number? 5 into 10. Okay, somebody asked for 550. Okay, go down. And then hold the position. Hold that position. Hold that position. What? Look at, and then hold it, hold it, hold it, hold it, hold it. Okay, there is, can you all feel your shoulder? Yes? Okay, you can feel the neighbor's shoulder also, no? Yeah, okay, fine. So, there is a way to prescribe push-up. If you know on an unstable shoulder, it's one of the safest exercise, post-surgical, okay? Last time in the same conference, I had a huge argument with the surgeons, okay, about prescribing push-up. Hey, no, I didn't ask you to sit, come, please. Yeah, okay. I'll tell you how to prescribe push-up as an exercise early. You want to know, yes? Yes? Okay, I'm going to show you how it is done. Only if you get out of your chairs. Come on, get out of your chairs. Get out of your chairs. Get on your quadruped position. Get on your quadruped position. Get on your quadruped position. Quadruped, you all know what is quadruped. Okay, go to a position in which you want to do push-ups. Say for example, flex your elbow, go down for 60 degrees. Whatever is according to you 60 degrees. Okay, hey, these guys were responding very slow to me. Okay, so that's why I'm doing this. You give me 5 more minutes. Go down and then go to 60 degrees. Now lift your knee up, extend your leg, hold that 60 degree. That one. Okay, and then hold that position. Hold that position. No. Lift, stretch your knee out on your toes. Go into the, lift your knee up from the, that one. Okay, hold it. Now, touch the knee back. Don't change the position of your elbow. Touch the knee back. You come to the core. So, your shoulder movement has not changed. You understood? Now, I want you guys to do 45 degrees of shoulder flexion. 45 degrees, go down. No, get the knee. Yeah, 45 degrees, go down. Yeah, lift the knee up now. Lift the knee up and hold 45 degrees. Excellent. Now, touch the knee. And then come up. Okay, 60 degrees now. 60 degrees. 60 degrees of flexion. Lift the knee up and then hold. Okay, touch the knee. Touch the knee. 45 degrees. Lift the knee up. Hold. Okay, touch the knee. 60 degrees. Lift your knee up. Hold. 45 degrees. Lift the knee up and hold. Okay, that's how you prescribe push-ups safely. And if you work multiple point in range, okay, you work 60 degrees, 45 degrees, multiple. I've just given you a trade secret. You understood? I've given you a trade secret. Go and do it on your patients with shoulder instability and then thank me in your dreams or wherever you want to. You understood? If you have this ability, the patient will breeze through the push-ups like nothing. You understood? It will fix deficiencies in the range. Everybody knows how to prescribe eccentrics for subscap? Yes? No? Subscaps, eccentrics? Resistance band? Theraband? Yeah. Hold it. 2 minutes. They're not giving me a lot of time. Okay. So subscaps eccentric. Okay. Can start here. Can you see this? My elbow is in front of the shoulder. Easy. You understood? Easy. Elbow at the level of the shoulder. Progression. Okay. Once you hold here, rotate your trunk. Progression. Push your arm. Progression. Hold here and then do eccentric. Okay. Elbow in front. 1. Elbow at the level. 2. Turn your trunk. 3. Move your arm away. 4. And then move your eccentric there. Progression for eccentric. Outer range eccentrics. That's how you address apprehension. One more secret. Okay. End range perturbations for a shoulder instability. This is how I clear patients. Benjamin, you are a strong guy. Come. So, sir is here. Sir, this is what I am doing in the OPD before I send the patients to you. Okay. Post-surgical patient. Any patient with shoulder instability, okay, if they are not able to do this, then their shoulder is not ready. Okay, I'm going to do this. You understood? Yeah, just hold it there. I'm going to do it. Yeah, hold it there. Yeah. End range perturbations. You understood? It looks dangerous, but it's a lot more safe. If you know how to time this, you see what I'm doing? I'm pushing the elbow in and then push shoulder back. You understood? And my progression would be to keep the elbow in and then elbow here, elbow here, elbow here. Okay, this is, if the patient passes this, then I clear him. This is not fun. I know how to build capacity for this before I test him. This is not an Instagram exercise. Do you see me putting exercises on Instagram? I don't do. Okay, but this is what I do. Okay, give patients the ability to do this, and this is exactly what I do. And there is a way by which you get the patient to do this. Okay, that's what is called as rehab. Yeah, instability rehab. If you don't do push-ups, then it's not going to work. Yeah, next one. So slap injury, calisthenics, you have to know how to do biceps load and end range stability. Exercise 1, 2, 3. Biceps load management, because the mechanism is traction and compression, both traction and compression at the biceps anchor. End range stability, rotator cuff, and you have to prescribe movement transition. Okay, no time now. I'm going to show you how do we program this patient. I'm going to show you. I just only asked you to do 3 exercises. I'll show you the rehab program, how it is done. When a patient comes to you, there are at least 4 problems. There are not 1 problem. There are 4 problems. Inadequate upward rotation, eccentric adduction failure, excessive elevation, and poor external rotation strength. That's why the patient is failing like this. This is caused because of serratus anterior inner range control, lats extensibility, extension stability of the trunk. If there is no extension stability, there is nothing. Eccentric adduction failure happens because of poor lower trapezius control, excessive load or shoulder instability. Excessive elevation is usually a compensation or an overactive levator. External rotation strength because of the transition. For you to lift the load up, you also have to transition. That means take the load, transition, and then press it up. This is your external rotation strength, and because people don't have good transition ability, they can't hold the load. Does it make sense? So those are the possibilities. And then you do 3 exercises for each one of them, and those are the exercises: inner range, hold, pike push-ups. Okay, I straight away go into pike push-up for him. That's the best upper rotation exercise. Because you guys don't do push-ups, I can't teach you how to do pike push-ups. And then you put it here in phase 2, range and strength. Okay, but the guy is a CrossFit athlete. You have to know how to prescribe late stage shoulder rehab, how to do barbell, squat, thruster, and push jerk. For speed, there are different exercises. For power, there are different exercises. I told you about movement integration, different set of exercises. If you look at it, different prescriptions: 4 sets 5, 3 sets 8 to 10, 3 sets 6, and it has to be sandwiched between your exercises. This is an art. Okay, and you have to put it there. Otherwise, the patient is not going to go into sport. And then you are a physiotherapist, so you should know this. Where is my blue TheraBand exercise? If it is not there, then there is no shoulder rehab. The blue TheraBand exercise usually goes here. Okay, phase 1. So that's how you do a rehab program. It's called as rehab program design. I teach this. You know what is the best part of being a physiotherapist and not be able to be replaced by ChatGPT? I gave you one scenario. Then comes an entirely different scenario. Patient is a swimmer and comes with a scapula forward tilt and symptomatic. The fun is building something like that for this patient. You understood? Something like this, entirely different, and then doing something for swimming, and then the reasons and the cause for it. Even more fun. And then comes, guys, these are part of the sport. Winging in a boxer, protraction in a cyclist. And then comes guys who actually do this, and do this. Always who the patient is, okay, how do they use their shoulder, what their problem is, and then you have fun doing this for each one of them. That is why I'm always on a high. Yeah, because this is exactly how the practice is. And that's what makes me do this. Okay, thank you. Good. Yeah. Yeah. Questions? Specific? Yeah. 2 questions for the lack of time. Okay.
How soon can we start with the push-up in early post-operative cases?
Are there surgeons here? It depends on the surgery. You will communicate very closely. Fortunately, I work with someone who's going to tell me exactly what went on in terms of tissue quality and all that. I won't do push-up on a non-athletic shoulder. Does it make sense? Okay, I will do and then call it something else. That's a different story. But
How do you grade an athlete? Suppose if a person is a
if it is a capsulolabral repair, capsulolabral, that means your slap tip repair, bank cards and all that stuff. I won't do a push-up on a rotator cuff. I will wait a little more longer, for example 2.5, 3 months. But then I will load a capsulolabral repair a little early. Okay, if you know how to modify the push-ups as early as 6 to 8 weeks.
So
Okay,
modified push-ups can be given.
you call it modified, yeah. I'm not doing push-up as a motion. Okay, that means closed chain loaded stability exercises in the healing phase. Okay, once it is healed, once the scar tissue has formed, you understood, you can't influence the tensile properties of the muscle. You understand? I told you about proprioception, whether you are prescribing for proprioception or you want to make sure that the capsule becomes stiffer. Okay, so that's why you will
So
prescribe.
suppose if it's not a labeled athlete, somebody is already playing for a long time,
Yeah.
and they come with a shoulder injury, do we take them in an athlete category or?
Okay, anybody who does push-up has an athletic shoulder. Okay, anybody who does yoga, anybody who does fitness, that's why I started the program like that. It's not just the throwing shoulder. If you do fitness, if you do lift weight, if you do yoga puts a lot more stress on the shoulder, okay, than you know, compared to. And the good thing is the athletes are physiologically adapted shoulder. Non-athletes are non-adapted shoulder. They are much more difficult to actually treat. Okay guys, thank you. Okay, I think I took 10 minutes extra. Cool.